Hello, everyone. Thank you for standing by and welcome to our webinar, The Science of Skin to Skin and Kangaroo Care, sponsored by IsisParenting and presented by Hope Parish and Daniela Jensen. My name is Nancy Holtzman. I'm the Vice President of Clinical Content and Online Learning here at IsisParenting. I'm also a mother-baby nurse specialist and a board-certified lactation consultant. During tonight's presentation, all participants will be in a listen-only mode. However, you may submit questions to us at any time by typing them through the chat feature located to the left of your screen. We've incorporated many of the already submitted questions into the presentation and will take additional questions at the end. This webinar is being recorded and you will receive a link to the recording by email tomorrow along with additional resources. So if you missed something or need to step away for any reason, that's okay. IsisParenting is proud to host this evening's webinar. ISIS is the nation's most trusted prenatal and early parenting destination. We provide innovative programs and a highly edited selection of products for expecting and new families in our 4 Boston area centers and online at IsisParenting.com. Watch for our new centers opening this June in the Atlanta, Dallas, and Fort Worth areas. As I've mentioned, I'm Nancy Holtzman, and I'll be your moderator this evening. Let me introduce our presenters. Hope Parish has practiced medicine for over 15 years as a physician assistant, earning a master's degree in medical science in 1999. Daniela Jensen hails from a marketing and advertising background, building Hasbro's most recognized toy brands. They each fell in love with the practice of skin to skin with the birth of their own children and have gone on to become certified through the United States International Kangaroo Care Foundation to teach and instruct. Throughout their training, Dr. Susan Ludington-Ho has been a tremendous influence and mentor. Hope and Daniela are the co-founders of Nuru, developing products designed to foster the bond between mom and baby. Their first launch is the Nuru Pocket, a baby-wearing shirt designed for skin-to-skin contact. Hope is the mother of 3 beautiful children, and her goal is to implement the Nuru Pocket for inpatient hospital use, allowing all moms and babies, premature and full-term, many hours of skin-to-skin time. Daniela has 5 amazing children and lives with her husband in Rhode Island. She aspires to identify solutions designed to keep mom and baby together. Welcome, Hope and Daniela.
Thanks so much, everyone, for joining us on International KC Awareness Day. We have a ton of material to cover and want to leave enough time for questions, so we're going to jump right in, starting with what is Kangaroo Care?
So the terminology used to describe the practice of kangaroo care varies. Commonly, we've heard it referenced as skin-to-skin contact. The research articles and NICUs cite the practice as kangaroo care. And when performed only by the mother, it can be called kangaroo mother care. Not to mention when immediately placed after birth, it's referred to as birth KC. Confused yet?
Either way, they all add up to the same practice, a holding technique where baby is placed vertically, bare chest to bare chest with the provider. You'll hear us talk about kangaroo care as a practice, and believe it or not, there's a right and a wrong way to do it. So let's ground ourselves with the history.
So kangaroo care originated in Bogota, Colombia. Picture a very impoverished city with limited access to medical facilities and resources. In the NICU here, babies lacked proper nutrition. Often mothers were abandoning their children. Overcrowding and shared incubators were a common sight. Given these circumstances, 80% of all preterm infants born were failing to thrive. Dr. Sambria and Dr. Hector Martinez introduced a method to alleviate the shortage of caregivers and lack of resources.
They witnessed a grandmother in a remote village holding her grandchild under layers of clothing and wraps tucked between her breasts and her bare skin, and they commented that it was like a kangaroo carrying her Joey in a pouch. They were shocked to find that the babies in this village were thriving. Returning back to their work, they implemented what they saw at a hospital where the average temperature was only 50 degrees.
They suggested that mothers have continuous skin-to-skin contact with their low birth weight babies to better thermoregulate and provide proper and continuous breastfeeding nutrition. Over the course of their first year, they observed a 10% reduction in the mortality and morbidity rates simply by keeping mom and baby together. The incubators were no longer crowded, and with the increased bonding, fewer and fewer women were abandoning their children. The physicians presented their findings in 1983 at the first global conference of fetal neonatal medicine in Bogota. This became truly the aha moment for the rest of the world.
Given their findings, KC transitions from these low-income settings to affluent societies with the focus including both pre- and full-term newborns. Countries like Norway and Sweden were quick to embrace KC, implementing the practice 24 hours a day as part of their routine hospital care, and this included the involvement of dads. Postpartum practices became keeping about mom and baby together, beginning with in-rooming, 24 hours a day KC, limited intervention. Babies were allowed to leave the hospital with dad under the philosophy that fresh air was healthy for them.
Early research shows that when baby is uninterrupted in Kangaroo Care, they will naturally go to the breast and feed when hungry versus routine, regimented breastfeeding intervals and a forced latch. Commonly, even today, we find here in the States that breastfeeding moms are told to feed baby every 2 hours, and sometimes this forces a latch and can even produce aversion to the breast, where baby has natural instincts, and when baby's held skin to skin, baby's going to seek out that breast and latch naturally.
During the 80s and into the early 90s, just like this picture shows, the U.S. was focused on intervention. So you're seeing lots and lots of machines, medicine, etc. The rest of the world was comfortable and convinced, but in order for us to implement Kangaroo Care here in U.S. hospitals, U.S. research needed to establish their own data and evidence. The thinking really needed to shift from this artificial induced environment to the benefits of baby's natural habitat. Hindsight is 20/20, right? So knowing what we know now, this slide looks backwards, where the control group should be keeping mom and baby together, and the experimental condition should really be the artificial setting.
So collective results over the last 20 years tells us that mom is able to stabilize baby equally, if not better, than baby being placed in an incubator. These findings were gathered from information focused on heart rate, respiratory rate, body temperature, and oxygenation levels. This research set up a demand for change.
So fast forward to where we are today. The World Health Organization states that all infants greater than 28 weeks should be given skin-to-skin care starting immediately after birth to minimize infant mortality and morbidity. Back in 2007, the American Academy of Pediatrics was advocating for skin-to-skin immediately after birth, and then they updated their recommendation in 2012 to include that skin-to-skin continues throughout the postpartum period, stating that healthy newborns with no evidence of respiratory compromise will be placed in direct, uninterrupted skin-to-skin contact with their mothers until the completion of the first feeding and throughout the postpartum period. So the global agenda was heard, and as a country, our Surgeon General and Center for Disease Control has implemented our national initiatives for advancing the care of baby through skin-to-skin contact and breastfeeding.
So how do we go from these large global initiatives and national recommendations to impacting mom and baby's experience here? So breastfeeding and skin-to-skin has been defined as our national standards and is now being measured in our hospitals by the Joint Commission. The Joint Commission has created 5 perinatal core measurements, and within those measurements, one of those 5 is how well hospitals are initiating breastfeeding. And we know with skin-to-skin contact that there is a direct correlation and relationship between the two. Last year, Kentucky completed skin-to-skin training in 100% of their birthing hospitals. So all healthy term infants and stable preemies receive skin-to-skin within minutes of birth and beyond. This has now set the precedence for the rest of the country to follow. Hospital staff, lactation consultants, educators, moms are all telling mom to practice skin-to-skin as often as possible throughout those first 12 weeks.
The practice is recommended by the American Academy of Pediatrics, the College of Obstetrics and Gynecology, Association of Women's Health. We could go on and on. But really, going back to this right and wrong way to practice Kangaroo Care, let's talk about the science behind the C afferent nerve and really how and why everyone is recommending KC. So everyone has a nerve, coined the C afferent nerve, that is centrally and ventrally located from your collarbone to your sternum. This nerve only responds to pleasing human touch, and when it's stimulated, it sends a message to the brain to produce a hormone cascade, predominantly oxytocin. These hormones are responsible for the benefits of the practice to both mom and baby.
And I want to caveat the importance of this slide. In my opinion, this information is being overlooked. And when mom learns about skin-to-skin contact, she is so surprised that there is a nerve-driven response. If you're going to take anything away from tonight's lecture, the importance of proper practice is what stimulates that nerve response which delivers these benefits. And I am forever grateful for the experience that I had with my third baby, that my nurse midwife took the time to explain the physiologic benefits and action of this nerve.
And not only that, and the importance of KC immediately after birth, but this is a practice that the benefits continue. Research does not quantify that these benefits end at a certain time. So we hear a lot, you know, my baby is 6 weeks old, have I missed the window to give them the benefits of skin to skin? Absolutely not. They are advocating for as often and as continuously as possible.
The following skin-to-skin mnemonic was developed by Dr. Susan Luddington and Dr. Barbara Morrison, which outlines the evidence-based findings over the last 30 years. Each of these slides could truly be its own lecture, but there just isn't enough time tonight to develop each one of these benefits we're about to share. So instead, it's meant to give you a top-level overview. The first S of the mnemonic stands for safe practice and proper position of the baby. Since skin-to-skin contact means skin-to-skin, chest-to-chest contact, so that the entire ventral surface from the umbilicus to the sternum or from the belly button up of the infant is against the mother's bare chest. Baby's shoulders are against the mother's chest, connecting an invisible line from shoulder to shoulder and down to their belly button as if it was a reverse triangle. Mom should be completely bare-chested. Even wearing a bra could disrupt this nerve from firing. It's recommended that mom is in a semi-reclined position and not lying flat, as this could make it hard for baby to breathe. The mother should be able to see her infant's face at all times. The mother should not be sedated with medications, and the mother should have the nurse or family present to watch the baby during skin-to-skin care, which is why the oxytocin, which is that feel-good hormone, is going to make both mom and baby very dopey and happy, which leads to sleep. So to have a provider or a member with them in the room to keep them safe is recommended. The infant's body is flat against mom's chest, between her breasts or on her breast. It's important to remember that the infant's body is covered with 4 layers of a light receiving blanket. The infant's head is turned sideways when not feeding at the breast, and the infant's face is uncovered and the head is covered with a hat. The infant's neck should be straight and not bent, as well as that chin should not be tucked to chest or curled in.
So the next slide talks about a kinder, more gentle environment, and this is signified by baby's natural environment, which is with mom. The photo that you guys are looking at is a photo of my baby taken 4 years ago. If I only knew then what I know now, and if I had $1 for every time we heard that. My daughter was placed skin to skin, just not immediately after birth, and what you see in this photo is the result. So separation from the mother's skin increases stress levels for the infant, which is demonstrated in the picture. Infants show a protest despair response, first evidenced by crying, and then followed by extensor activity, which is outstretched arms and legs. These behaviors correlate to a higher level of cortisol, which is a stress hormone. High levels of cortisol can lead to physiologic instability in baby. If the separation persists, the infant progresses to the despair phase, evidenced by a decrease in temperature and heart rate. So a crying baby at birth used to be the sign of healthy lung function, right? How many times have you heard that story where they actually spanked a baby after birth to elicit a cry? Now we know that that cry is a sign of stress and despair.
I saw the benefits firsthand with my last baby. After she was born, she was immediately placed on my chest, and I was anticipating the cry, waiting for the cry. She never cried. And actually, her not crying induced anxiety for me, as I was taught and told that that cry was what was important, when really she had everything she needed being right on my chest.
So research shows that immediately after being placed skin to skin, the infant's cortisol level drops. Immediately after being placed skin to skin. After 20 minutes of uninterrupted skin to skin, infant cortisol levels have been shown to decrease more than 72%. So if you had a way to increase your baby's stress by 72%, wouldn't you do it? So within 30 minutes of the onset of maternal skin to skin, this is the norm for mom. Her cortisol level drops 89%. So not only are there benefits in stress reduction for mom, but also for baby. Or mom and baby.
Thus, our focus has shifted to a non-separation model. So we see this with the baby-friendly initiatives, which was started in 1991, which was to encourage and recognize hospitals and birthing centers that offer an optimum level of care for infant feeding and mother-baby bonding. Initiatives include rooming in and breastfeeding as the standard of care. The parent-infant relationship is nurtured by frequent skin-to-skin contact, and when baby's on mom's skin, mom is more sensitive to baby's needs and responding more quickly to baby's cues, which also supplies her with a sense of confidence and improves her self-esteem. The sensory stimulation provided by the mother's breathing, her heartbeat, her skin, voice, and her natural scent increases baby's brain complexity and actually accelerates their brain maturation.
So the next slide stands for immune system benefits. I know there were a lot of questions about this. What mom doesn't want to enhance their baby's immunity? Starting skin-to-skin contact immediately after birth limits infants' exposure to harmful bacteria. Your bacteria is colonizing babies before that of the warmer and the hospital environment. The mother's mature immune system produces antibodies that she passes to her infant through both skin-to-skin contact and breast milk. Early and frequent skin-to-skin contact is going to reduce the risk of nosocomial infection because when your skin is intact and well hydrated, it provides a larger barrier for defense. So skin-to-skin contact is going to protect the innate defenses of the infant's skin by increasing skin hydration and decreasing heat loss.
And for newborn nutrition. In terms of nutrition, the name of the game is for baby to gain weight. It is anticipated that babies will lose weight prior to them gaining it back, which is why mom gets a high five from her pediatrician as baby is back to their birth weight at that first visit. So mom thermoregulates baby. Skin-to-skin contact preserves those natural carbohydrate stores, also known as brown fat, and this facilitates metabolic adjustment in the infant after birth as the baby is not burning fat stores to stay warm because mom's doing the work for him. Because they're able to maintain those carbohydrate stores, they are maintaining a normal blood glucose level, even in spite of not feeding at the breast in the first 90 minutes after birth. These benefits are provided irregardless if baby is breastfed or bottle-fed. We know that with increased oxytocin levels, it helps regulate digestive hormones also, such as gastrin, cholecystokinin, and somatostatin. Through these channels, baby has a higher level of absorption of nutrients leading to weight gain, which is why skin-to-skin is commonly recommended for babies with reflux as well.
So it's important to note that all babies benefit from skin-to-skin regardless of mom's decision to breastfeed. However, skin-to-skin contact in the first 3 hours of life increases the amount of prolactin receptors mom has, which is going to lead to a larger milk supply for mom. The more receptors she has, the more milk she will continuously make.
Skin-to-skin and breastfeeding are coined the breast relationship because its effect on breastfeeding initiation, duration, and exclusivity. Babies latch better and are feeding more frequently. The suckling at the breast and the pulses of the oxytocin from skin-to-skin produces higher levels of prolactin, creating a positive feedback cycle for mom's milk production.
Keeping with that mnemonic, the T is for thermoregulation. Skin-to-skin contact provides a thermoneutral environment that maintains the infant's temperature at a level that requires the minimum expenditure of oxygen and energy. Because we know oxytocin is pulsing through mom and baby, it's the presence of this hormone that helps her to regulate her breasts. Not only can she heat her baby, but her breasts have the ability to cool down a warm baby. Interestingly enough, her breasts also act independently. So if mom has multiples, as the picture shows, she can warm the cooler baby and cool the warmer baby. It's pretty amazing. As we noted, in proper positioning, the infant's back should remain covered with 4 layers of receiving blankets. Preterm infants are more quickly to warm on the mother's chest than full-term infants. It takes a preterm only 3 minutes to begin thermoregulating, where it may take 30 to 45 minutes for a full-term infant to bring that measured temperature up, since heat starts at the core and then begins to diffuse outward towards the extremities.
Always for other options. So what we're learning now and what we're seeing in some hospitals is Kangaroo Care in the OR, which is needed. As you can see, 35% of all babies are delivered via C-section, and the numbers are growing. So the focus now is enhancing the maternal-infant bonding with early skin-to-skin in this environment. Anesthesia is adjusting the way they prep and prepare mom in the OR to support early skin-to-skin and breastfeeding. So what does that mean? That means that when the anesthesia comes in prior to taking mom back into the OR, they're freeing up mom's dominant arm so that oximeter, the IV, the blood pressure cuff, all of that goes on mom's non-dominant arm. The EKG chest leads are also placed on mom's back to help facilitate that full chest-to-chest contact that's needed. These give mom the option to give mom the option to view the birth of baby. Mom can request using a clear drape. Mom wants to feel involved and witness her baby being born, and this is a great way for her to be there and have that. They can also put that surgical drape in a more creative place versus right under mom's breast to create more space on mom's chest. If mom and anesthesia can advocate for that sheet to go further down towards her belly button, that's going to help.
So if mom is not stable, the O in the mnemonic stands for other options. The benefits of skin-to-skin are not just for biological mothers. If we go back to the nerve stimulation piece, every human has those C afferent nerves down the center of their chests. If the mother is sedated or too ill to participate in skin-to-skin contact, the next best option is to put baby right with the father so that he can hold baby skin-to-skin after birth. Fathers report stronger feelings of closeness with their babies and can give them all of the same benefits as mom. However, infants can become too warm in paternal skin-to-skin contact after 90 minutes as their breasts, or lack of breasts, I should say, don't regulate like a woman's do. So you need to monitor baby's temperature. We talked about skin-to-skin in the OR, but there are also beautiful, amazing stories of parents waiting in a bed next to the birth mother or the surrogate and practicing kangaroo care with their babies immediately after their birth. Returning home from the hospital, Casey can be provided by siblings, grandparents, etc.
S is for state and sleep outcomes. So for state, we wanted to talk about the pain reduction. So what we know in skin-to-skin is that babies perceive less pain, which is really important for those babies that are hospitalized or being monitored in the NICU or even that full trauma with jaundice where baby has to undergo routine heel sticks. Mom and staff should be advocating that baby stays on mom's skin during these routine heel sticks. We often see with skin-to-skin and pain that the baby will cry less or not at all. And going back to those cortisol levels that we had discussed, the pain will drive this, but skin-to-skin contact has implications for reducing earlier traumas experienced by the infant. So as for sleep outcomes, there's two different types of sleep that babies experiencing, quiet sleep versus active sleep. So the functions of sleep, we know it's for restoration, learning, memory, growth, and development. There are two types of patterns. So with active sleep, we see some movement. We see movement of the arms or legs, little twitches, changes to your irregular breathing patterns. This is the dream state where you have REM sleep. Quiet sleep means very little movement with nothing that's changing the breathing pattern and no REM state or dreams. So cycling between REM or cycling between quiet sleep and active sleep is very important. It's not so much the duration of each or the density of any sleep stage or the number of stages or episodes, but it's the cycling between the quiet and the active is what is important. And to cycle takes us truly 60 minutes to complete. So during that time, those neuronal synapses and growth are what's occurring during those sleep cycling. So ideally, this is what we'd like to see. Baby completes one sleep cycle in an hour.
So when you hear us talk about the benefits of skin-to-skin and it being an uninterrupted 60 minutes, this is where that 60 minutes comes from. So like we talked about, benefits begin immediately with reduced crying and temperature regulation, but it does take a full 60 minutes to complete those sleep cycles.
So moving into this visual, it shows a chaotic EEG pattern. And what we're looking at here in the beginning is there's this dyssynchrony of breathing, heart rate, and the sleep pattern prior to baby being placed in Kangaroo Care, which is where we see the squiggly and chaos of all those lines. In Casey, we start to see the ideal sleep cycle come back, where the heart rate and the breathing is organized, and with better organization leads to better brain firing patterns, which we will see when we talk about the brain development in a minute. What we know about quiet sleep is that quiet sleep blunts the release of glucocorticoids better than active sleep and wakefulness. And it's these high level of glucocorticoids that can cause cell death and induce stress. Quiet sleep is also associated with remodeling of the connections between the brain cells called synapses, which permit the processing of the information acquired during wakefulness. Quiet sleep allows for optimal conditions for brain organization to occur. Although quiet sleep has significant benefits, without active sleep and a proper sleep cycle, baby can be at risk for SIDS. So K for cardiorespiratory outcomes. So what we know from looking at the prior slide is that with skin to skin, there is a synchronization of heart rate, breathing, and sleep cycling together. But looking at the stages before Kangaroo Care, during Kangaroo Care, and after Kangaroo Care, like in this slide, what we see is organized and regular breathing and heart rate patterns. The infant is now self-regulating during Kangaroo Care, resulting in a 75% reduction in episodes of apnea and bradycardia. Intentional bonding, I is for involvement of parents. So mothers who hold skin to skin increase their oxytocin levels and respond with more nurturing and affectionate behaviors toward their infants. And an increase in oxytocin levels also promotes that bonding and attachment. Dads are more interactive with their infants and report a stronger bond long term if they've had the opportunity to hold baby skin to skin. We also note that infants are calmer, they cry less, they fall asleep sooner when fathers hold skin to skin when compared with infants that are swaddled and held in arms or placed in cribs.
N is for neurobehavioral development. So several longitudinal studies show continued expression of the closeness, mutuality, and synchrony between parents and infants with immediate and ongoing Kangaroo Care. During the first 3 years of life, the brain and central nervous system are the most formative and can be changed by environmental events. So think of the brain creating roads and pathways for the neurons to fire. Once these pathways are established, it then becomes automatic. This is why, for example, language is much easier for younger children to learn, because it is this time that their brain is doing the wiring. What you see in the slide is the limbic system. It's the emotional system of the brain, and it's the site for memory retention, established self-esteem. It's also the seat of all emotions: hunger, thirst, anger, aggression, love, compassion, empathy, sympathy. It is within the limbic system that you find the amygdala, divided into a right and a left side. The left is responsible for fear, violence, and the state of unfeeling, if you will, where the right is responsible for all of your positive emotions. When baby is held skin to skin early and often, their breathing and heart rate is synchronized with mom, and their cortisol levels have dropped, leaving them in a pleasure state. The left side of the amygdala, remember this is the negative behavior side, is down-regulated, allowing the right side to be the dominant, favoring contentment, sympathy, empathy, and relaxation processes. So basically, you're wiring the brain to respond to the positive, and the best stimulation to hardwire that system is through pleasing human touch.
So these are some of baby's benefits in review that we've touched on. The brain development, reduced crying, stress, body temperature, quality of sleep, enhances the immune system, stimulates digestion, weight gain, synchronizes heart rate and breathing, and encourages breastfeeding behavior. So let's spend some time on the benefits for mom.
So skin-to-skin contact is going to stabilize the mother's blood pressure and allow her cortisol levels to lower. The increased level of oxytocin is going to contribute to mom's physiological well-being and reduce her risk for postpartum depression. We talked about the milk production briefly, but there is a dose-to-dose response between the amount of time baby spends on mom's skin and the amount of milk that she's going to make,
as well as the exclusivity and the duration of her breastfeeding.
So knowing the benefits of skin-to-skin, how do we implement this in our birth setters? How can we get management on board? What does mom need to know what to ask for?
So we advocate that mom should make this known during her birth plan. Prior to labor and delivery with her healthcare providers and her team, she should have a voice in regards to how she wants baby to be born and to room in with her and not be separated and taken to the nursery. Those first 24 and 48 hours are critical to successful breastfeeding, and skin-to-skin optimizes the exclusivity and duration. If baby's 36 weeks plus and medically stable, should be immediately placed on mom's abdomen to be dried. Nose and mouth can be suctioned here. A head cap should be placed on baby's head, and a blanket should be placed over baby. Once the cord is cut, baby's diapered and placed directly on mom's chest, so they are chest to chest, allowing 60 to 90 minutes of uninterrupted skin to skin, as baby will spontaneously crawl towards the breast and start their first feeding. Baby can be given all routine treatments, eye drops, vitamin K injection, as well as routine medical assessments while on mom's skin. The first pass can be and should be delayed for those first 12 to 24 hours, as that vernix, which is that white pasty cream that's on baby's skin, is a special coating that delivers antioxidants, antibiotics, and the scent of it actually aids in breastfeeding.
So nowhere on here do you see, for all of the providers listening, to ask permission that baby be placed skin to skin with mom. And this is something that we are hearing more often than not. It is becoming standard of practice. So providers are not asking, hey mom, do you want us to wash the baby? Do you want us to take baby first, clean them up, and then give them back to you? This really should be routine. And so from research and science to these large global initiatives to our best practices, there is one shared message: as early, as frequent, and as often as possible. So today is Casey Awareness Day, and now that you're in the know, what will you guys do with all of the information that we just shared? How will you guys advocate? Hope and I came home from the hospital charged and empowered. We heard this information from our wonderful nurse midwives, and we had very incredibly active households and struggled to find the time to hold baby skin to skin. And this is really where support comes into play. I think that you can practice skin to skin. If you have the ability to do it bedside or on the couch with something over you, great. With other children, I know that can be incredibly difficult. So there are carriers, slings, etc. For Hope and I, we were really looking for something that suited our needs and couldn't find something on the market that did exactly what we wanted to. We were looking for full coverage and mobility. And, like I said, we couldn't find that offering, and so we designed the Kangaroo Pocket. It's a baby-wearing shirt, especially for skin-to-skin contact. It gives mom that full coverage and mobility. It's incredibly easy to wear. Forget the wraps, the straps, the ties. I know that there are a lot of barriers to women with wraps, that they can be difficult or complicated. So we were trying to remove all of the challenges that mom faces and really give her the ability to practice skin-to-skin as often as she can with baby. So if you're interested in learning more about the Kangaroo Pocket, visit NuruBaby.com. It's also available in all of the ISIS centers. And I hope that we have some time for questions.
Thank you so much. We did have a lot of questions. They tended to follow some themes, so I think we'll ask about these themes. Can you speak a little bit about the length of skin to skin in terms of each segment? So I think a lot of parents are concerned when they hear that the full benefits or all the benefits come from 60 minutes of skin to skin. But in what ways would even 20 or 30 minutes of skin-to-skin contact be beneficial?
Great question. So we know through research that baby can start to warm within those first 3 minutes. So we know with thermal regulation that's almost happening instantly when baby's on mom's skin. We also know with cortisol or stress hormones that there is a reduction in this stress response in both mom and baby, again within minutes, and seeing those full benefits at 20 minutes. We also know with the heart rate and respiratory rate and the synchronization of those are also happening within the first 30 minutes. And in terms of overall well-being and mom connecting to baby's cues and responding quickly, That's also happening within minutes. I think when we speak again to those full 60 minutes, what we're really looking at is the sleep cycling and the brain maturation, but many of those benefits are occurring prior to 60 minutes.
Excellent. Thank you. Can you speak a little bit about hospitals that may be more reluctant to embrace skin-to-skin, whether it be immediately after birth, they want to wash the baby first, or physicians ask to examine or weigh the baby before allowing skin-to-skin? I understand there's quite a bit of evidence-based practice standards being set now. So is there some backbone to pressure to allow the baby to go immediately skin-to-skin?
So I think you can answer this question twofold. One, for the providers, there is an incredible amount of research that is out there to support your cause. So if you are charged and empowered, use the studies, use the facts, because they are very difficult to argue. What we hear frequently is that, and I hate to say this on a recording, but that when providers receive a lot of resistance from supervisors, they're doing skin-to-skin in the NICUs or in the OR kind of under the radar, and then they're able to slowly and surely incorporate that. A lot of the success stories of how did you get this practice to be embraced by your hospital began with one person having a will and finding a way.
And I also think, too, for mom to find the confidence and knowing that when baby is born and is stable, that these are the needs of you and your baby, and to directly communicate those to your team, and to be knowledgeable and educate yourself in this practice and truly advocate for yourself in that setting.
Excellent. Many questions about Kangaroo Care with premature babies, and some of the questions that came in ahead of time were, what are some things that you may be able to do before the baby is stable enough for Kangaroo Care, so in the event of a micro-preemie or a very early or unstable infant? And then what about the fact that it might be a week or 2 weeks or longer before a premature baby can go skin-to-skin for Kangaroo Care? Will they still receive the benefits?
That's a great question. So, again, I can answer this in multiple ways. I would say that for those parents who desire and long for that contact with their baby, to do pleasing human touch. And it doesn't necessarily have to be having baby on your chest if you can't do it just yet. Touching them and being present and having them hear you, and simply just the weight of your hand on them is pleasing to them at that stage.
And I think, too, the nursing staff in the NICUs, they're doing a phenomenal job. There's a couple different ways you can transfer babies safely from an incubator, even with lines and tubes. And as soon as you've gotten the green light that baby is stable enough, there are two different types of practices that can safely and securely have baby there on mom's chest. And I think that hospitals are doing a great job with that.
This is an interesting question, and I think it's a good one because there's a difference between skin-to-skin and Kangaroo Care and sleep. So this question is, how does what you're encouraging balance with the American Academy of Pediatrics recommendation to put the baby on their back to sleep?
So for the recommendation when baby's in a crib or not being held to be placed on back is the recommendation, and that is the safest sleep. When baby is on mom's chest, mom is there monitoring. Mom is looking at baby's nose and mouth. They're unobstructed. Baby's head is in a position where the airway is open. Mom's checking in. Mom's quickly to react. And so it is a very safe position for both of them to be. And again, with all of the evidence that we've presented here tonight, not only is it a safe place to be, but it actually can help stabilize baby. And there's a huge degree of confidence with that piece.
Yes, I think just to add that there is a difference between practicing Kangaroo Care and skin-to-skin and doing that awake and aware and for periods of time, rather than taking a very young baby and sleeping on the living room couch at 3 o'clock in the morning because that's the only way your baby will sleep and you're exhausted. That is a potentially very unsafe situation when the parent is asleep and the baby is asleep on the chest, because there's such a great risk for entrapment in couch cushions between the adult's body and so on. But that, even though that position may be similar to what the skin-to-skin position is during the day, parent is awake, alert, monitoring the baby, and it's not intended for sleep.
And just to add to that piece too, also to add an element of safety to the practice, because we know that the oxytocin is a very pleasurable response for mom and baby, and it does calm them and induce sleep, if you will. Using a device or a wrap like the Kangaroo Pocket also offers a level of safety. Baby is secured in the correct position, and if mom and baby do doze off, there is that level of comfort that baby is being maintained in a proper position, as well as in the NICU, which is also where our shirt is also approved.
Could you just reiterate the benefits of skin-to-skin care for the preterm baby, for the full-term baby as well as the preterm baby, and beyond the hospital period? So now I'm talking about, the going home, the week 2, the week 4, the week 6, that it's still beneficial even for women that are having breastfeeding challenges. It's beneficial for milk production and so on.
So I'm going to answer this and caveat the research. Research costs money, and the majority of studies are throughout the first 12 weeks simply because of the costs associated. There are several ongoing long-term studies that show that the benefits exceed far beyond this period. I would say that the benefits continue, that there is no cap for, practice skin-to-skin until your baby is X amount of time. Developmentally, baby is going to become very much more interested in the world around them, and they will lack the desire to be close and skin-to-skin, and where that happens and at what point is to be decided.
And I also think, too, obviously there comes a point in baby's maturation and development, especially the full-termer who's at home. No, they don't need that help to synchronize heart rate and breathing, and they don't need to be thermoregulated any longer. But I think the key message with skin-to-skin is there is a hormone that is released every time baby is placed on your skin, which is that oxytocin. And regardless of baby's age, that oxytocin is going to provide contentment, happiness, which we know that this hormone also leads to a better self-esteem, confidence as well for mom. So regardless of all of the true physiologic medical advantages, the one baseline is that oxytocin is going to circulate and always provide benefit for both.
Excellent. And I think, as I commented in the chat earlier, as you were going through the benefits, so many of these benefits reminded me of being similar to some of the benefits we see with infant massage, with baby wearing the baby in a sling or a soft carrier safely, and of course with breastfeeding. And so really all of these things do come together and emphasize the importance of attachment and closeness and the many benefits in terms of the baby's brain and neurologic and physiologic development and how important those things are. And it does reiterate as well for a mom who is not breastfeeding that she can still encourage the baby's development in so many of these similar ways, or a mom that's not a biological mom can still enhance all of these close features the same way. So I think we are nearing the end of our presentation. I wanted to remind our attendees tonight that I will send an email tomorrow with a link to this presentation recording as well as additional resources. I'm going to include a link to the webinar I mentioned, the Family-Centered Cesarean, which we did about a month ago, and it covered a lot of information about making the cesarean birth a little bit more encouraging to skin-to-skin to immediate breastfeeding, some of the same things that we covered today. Daniela and Hope, thank you so much for sharing this information with us and for coming on International Kangaroo Care Awareness Day. I know everybody in the audience tonight is a lot more aware of the benefits of skin-to-skin contact. Thank you all for attending. Please be aware that we have over 40 expert speaker webinars free and available on our website, so you should feel free to browse there, as well as a breastfeeding webinar that we offer every Thursday, and a infant sleep and toddler sleep webinar that we offer every Tuesday. So I will include the links to those as well. Thank you for attending, and we hope to see you at another ISIS online event soon. Good evening.